Good morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopaedic Principles. Today, our guest of honor is Dr. Prabhudevprasad Purudappa from Boston, Massachusetts. After completing his post-graduation in PG at Chandigarh, Dr. Purudappa pursued fellowships in Massachusetts General Hospital, Boston, adult reconstruction fellowship in the University of Minnesota, Minneapolis, and a fellowship in sports medicine at the Orthopaedic Center. He currently serves as assistant professor in Boston University School of Medicine and attending orthopedic surgeon at the VA Boston Healthcare in Boston. He's the editor of Archives of Orthopedics Journals and also serves as peer reviewer for several high-impact journals. He has published extensively across several top orthopedic journals and also has several high-impact publications to his credit. If you've noticed, Dr. Purudappa has lectured a couple of times on our channel, and it's already reached a huge audience. And today it's my great honor to bring back Dr. Prabhudevprasad Purudappa for this wonderful live program. Over to you, Prabhu.
All right, thank you very much, Hitesh, and welcome everybody. And today I'll be talking about instability in total hip arthroplasty. It's definitely a very important topic, and I'm sure many of you are interested in this. All right, so as we all know, hip replacement is one of the very successful operations, and many have even called it the operation of the century. But it's not without complications. And some of the common complications are aseptic loosening, which is probably the most common one, accounting for about 36%. And dislocation is most of the literature shows that it's the second most common, accounting for about 17% of dislocations, and infection being the third most common one. So dislocation is definitely a very important complication associated with primary hip replacement and revision hip replacement, obviously, which now we're going to talk about that in detail today. So how do we define instability? Like in any other joint in orthopedics, so we can classify that as dislocation and subluxation. A dislocation is complete loss of contact between the articular surfaces. And typically, it is following a traumatic event delivering some strong force in an otherwise normal joint, but could be secondary to some other unstable conditions in arthroplasty. And often, and typically, it requires an intervention. It has to be reduced under some type of anesthesia. And subluxation is actually a feeling of an incomplete dislocation, and it usually doesn't require any unusual or extreme circumstances, and it often arises during the course of daily activities, and often it is transient, and it is followed by full restoration to normal function. What's the incidence of hip dislocation? The annual rate of dislocation in a primary hip replacement. I will try to concentrate more on the primary hip replacement in this talk because we know in revision hip arthroplasty it is an important complication, and that can be a different topic also. So in primary hip arthroplasty, it has been reported somewhere between 0.2 to 10%. And the registry data have shown that it could be somewhere close to almost 2%. Large majority of these dislocations happen in the first 3 months. And in this study, this is an older study, but an important one, and it demonstrated that close to about 60% of the dislocations occurred within the first 3 months, and almost 77% of them happened in the first year after hip replacement surgery. So the cumulative risk following hip replacement surgery, the dislocation cumulative risk is about 1% in the first month, and it's about 2% in the first year, approximately. And it increases by about 1% every 5-year period, and it amounts to close to about 7% after 25 years. In this study, including about 20,000 primary hip replacements, there were 513 dislocations, and 32% of them were found to be late dislocations happening almost more than 5 years after surgery. And 55% of them were recurrent dislocation. So a dislocation is once there is a first dislocation, there is a high risk of recurrent dislocations. So it is not an easy complication to manage. So we have to pay attention to so many different factors when we are dealing with hip instability. So what are the common risk factors? We can classify them as patient-related risk factors. Female gender has been reported by some authors as a risk factor, but not everybody agrees with that. But we should be still careful. Elderly patients, definitely patients older than 80 years of age are at a higher risk because of various reasons, including poor muscle tone, and also because of cognitive problems. And then obese patients are at a higher risk. Total hip replacement after a femoral neck fracture. We know that many have demonstrated a higher risk of dislocation in this patient group. Patients with neuromuscular and cognitive disorders are at higher risk, and hyperlaxity and connective tissue disorders. Patients who are alcohol dependent and drug dependent. Previous hip operations, previous hip surgeries for any reasons, they are at a higher risk. Um, Rapidly progressive and inflammatory type of arthropathies, and also rapidly progressive avascular necrosis of the femoral head, also been reported by many authors as an important risk factor. And recently, there has been a lot of research regarding spinopelvic mobility and its relationship with the hip and the risk of dislocation when patients have stiff spine and decreased spinopelvic mobility. So we'll talk about that in a while. Just a quick slide about what are the things we need to consider when we are dealing with these risk factors, like patients who are alcohol dependent and other drug dependents. Very important, they are properly counseled, and they should be sober for several months before we consider any type of operation on them. Patients who are elderly, we should consider dual mobility liners and elevated liners. Obese patients, again, they have to be properly counseled, and they should go through weight loss programs. We know they are at a higher risk for many other complications, including wound problems and infections. Patients with neuromuscular and connective disorders, again, we can consider dual mobility liners, and direct anterior approach or direct lateral approach can be considered. Spinopelvic mobility, we'll talk about that in a little detail in a while. So we should evaluate them properly with good x-rays, and we should consider larger femoral heads, dual mobility liners, increasing the anteversion and appropriate combined anteversion when we are doing a posterior approach for these patients. And robotic assisted surgery can definitely improve the positioning of the implants in patients with spinopelvic mobility problems. So there are so many, if you look at the literature, there are so many radiological parameters have been defined to evaluate how we evaluate the spinopelvic mobility. So I'll just go through a couple of them, which can be easily done. So the first one is the pelvic tilt. How do we define pelvic tilt? It's the angle between the anterior pelvic plane, that's the plane passing through the anterior superior iliac spines and the pubic symphysis, and another line is the coronal plane. So this angle is the pelvic tilt. This can be measured on a lateral view X-ray of the spine of the pelvis, and it can be in the standing and in sitting position. So typically, the pelvis is slightly anteriorly tilted in a standing position. The anterior superior iliac spine is slightly anterior compared to the pubic symphysis, so it's tilted about 78 degrees when the patient is standing. And when the patient goes to sitting position, the pelvis tilts more posteriorly. This increases the anteversion. You can see in this patient with a fused spine, in the standing position, actually the pelvis is tilted posteriorly instead of anteriorly. And when the patient is in the sitting position, instead of tilting posteriorly, it's actually tilting anteriorly, which is abnormal, and that actually decreases the anteversion with the patient in sitting position, and that increases the risk of a posterior dislocation. Another one is the sacral slope. That is the angle between the superior end plate of sacrum and a horizontal line. Um, Typically, when the patient goes from standing to sitting position, the sacral slope and the pelvic tilt, they change somewhere from 20 to 35 degrees in a normal patient with a good spinopelvic mobility. So with each degree of increase in the pelvic tilt, that is the pelvis tilting more posteriorly, and decrease of the sacral slope, the anteversion increases approximately zero point 0.7 to zero point 0.8 degrees. So in stiff spine, which again, there are different definitions. One of the common ones is if the change in the sacral slope is less than 10 degrees, that can be considered from when the patient goes from standing to sitting position, that can be defined as a stiff spine. So in a stiff spine, when the patient goes from standing to sitting position, instead of the pelvis tilting posteriorly, it can it might tilt less, or it might even actually tilt anteriorly in a fused spine, thereby uh, thereby decreasing the anteversion instead of increasing it, which decreases the posterior coverage and thereby increases the risk of posterior dislocation. So there are many other risk factors. So these were the patient-related risk factors, and there are many other procedure-related and implant-related ones. So the common ones are the important ones are surgical approach is important, component positioning, soft tissue tension, soft tissue repair, surgeon experience, and then the implant-related risk factors are the femoral head size and impingement. Surgical approach, this has been studied by many authors. This is an older study, it's a meta-analysis by Massonis in 2002. This was the time when direct anterior approach was not used commonly. They demonstrated that direct lateral approach had the lowest incidence of dislocation of about 0.55%, and posterior approach without posterior soft tissue repair had the highest incidence of dislocation with almost close to 4%. Many authors have also reported after this, and a good meticulous posterior soft tissue repair has been demonstrated to decrease the dislocation, posterior dislocation to less than 1%. There has been, as you know, there's been a lot of interest regarding direct anterior approach in the last couple of decades. And there, again, there are many studies regarding the risk of dislocation associated with direct anterior approach. So let's look at a few of them. Mata and his colleagues reported on 437 primary hips. They report a 0.61% dislocation rate. This study in Journal of Arthroplasty, including 2,400 direct anterior approach hips and 4,400 posterior approach hips, demonstrated 0.25% risk of dislocation with direct anterior approach and almost 0.5%, which is twice the incidence in posterior approach. This joint registry study in 2015 involving 22,000 hips demonstrated a significantly higher dislocation rate with posterior approach of 1.4% than the anterolateral approach of 0.4% and direct anterior approach of 0.8%. This study in 2020, December, this was a meta-analysis of 25 studies, included 3,500 patients with direct anterior approach and 3,600 posterior approach group, and they found actually no significant difference of dislocation between the direct anterior and the posterior approach. So, with the more recent studies, it has been demonstrated that with larger femoral heads and using appropriate posterior, if necessary, posterior elevated liners and meticulous repair of the posterior structures of the external rotators and the capsule, the incidence of the risk of dislocation with posterior approach can be brought down to less than 1%, and which can be almost close to direct anterior approach and lateral approaches. Surgeon experience again is an important risk, so it's an inverse relationship. For every 10 primary arthroplasties performed yearly, there is a 50% reduction in the postoperative dislocation rate, and a higher dislocation rate was found among the surgeons who performed less than 30 total hips, as per this study. The soft tissue repair is in posterior approach is very important. This has been demonstrated by many authors. So the external rotators and the capsule, some surgeons take when they release them together. Some release them separately. But whatever the release technique, they need to be repaired with good technique to the posterior aspect of the greater trochanter, and this has found to decrease the risk of dislocation 10 times to about less than 1% dislocation rate. Component positioning, as we all know, is very important. A few slides about how what the good techniques of getting proper implant positioning. Acetabulum, the cup should be placed in appropriate depth, the medial lateral position. Appropriate height is the supero-inferior position. The angular placement is the inclination and the anteversion. Femur is equally important. Appropriate varus valgus position and appropriate version of the femur component is very important. The relationship between the cup position and dislocation again has been studied extensively. Levinek was the one who initially brought attention to this, and he was the one who defined the so-called safe zone. He demonstrated that the dislocation rate was 1.5% if the cup was in the safe zone and 6% if it was not. And he defined the safe zone as 5 to 25 degrees of anteversion and 30 to 50 degrees of inclination. In this study, Jones demonstrated a dislocation rate of 6.9 times higher if the combined anteversion was not between 40 and 60 degrees. But again, there has been many studies looking into the relationship between the safe zone and the dislocation rate. And this study by Mayo Clinic in 2015 demonstrated that a vast majority of the dislocated total hips were actually within the Levinek safe zone of the acetabular component position. So cup position alone does not predict the risk of dislocation after hip replacement. As we all know, it's very important to restore the normal anatomy, including the length and the offset and regaining the proper soft tissue tension. So component position is definitely very important, but the goal of a good total hip replacement is to recreate the normal anatomic geometry, which includes restoring the center rotation, restoring the offset, and restoring the appropriate length, thereby restoring the proper soft tissue tension and the abductor integrity of the hip joint. So how do we do a good hip replacement? Templating is very important. Again, it's two-dimensional. It is important to do a proper templating, but we know that it is not precise. It can predict the correct size from somewhere from 16 to 62%, and 50 to 98%. The sizes were either one above or one below in this study, and aim of the templating is not just implant size prediction, but to evaluate the appropriate cup position, the superior, inferior, medial, lateral positioning of the cup. Patient positioning is very important, especially in a posterior approach. We know that pelvis can be tilted significantly in the lateral position. It can the pelvic tilt can range from 25 degrees posterior to 20 degrees anterior. So it's very important to stabilize the pelvis with appropriate stabilization of the anterior subiliac spines and the sacrum. Navigation and robotics have been found to demonstrate to be helpful in accurate positioning of the cup. So in this study by Moskal, significantly higher number of cups were found to be in the safe zone, 80% compared to 62%, and a lower dislocation rate using navigation. In this meta-analysis, it was found that significantly lower number of cups were outliers when the navigation robotics were used. In other meta-analysis, 522 robotic assisted total hips and about 1,000 manual total hips. The robotic cohort had more satisfactory cup positioning, stem placement, and the global offset recreation. But again, this is, the cost is an important consideration, and especially in the beginning of the learning curve, it can increase the operative time significantly. So intraoperatively, again, achieving target depth is very important. So you need to ream medially to ream through these the pubic, ischial, and the ilial rims so that we get to the appropriate medial wall. Thereby, we can place the cup close to the teardrop. Transverse stable ligament is an important landmark to achieve appropriate height and appropriate anteversion of the cup. Again, we know combined anteversion is an important technique. So this gives you the a combined anteversion of the cup and the femur. And Larry Dorr et al. They published that the combined anteversion should be somewhere between 30 to 45%. If it is less than this there is a higher risk of posterior dislocation. If it is higher than this, there is a higher risk of anterior dislocation. How do we now evaluate an unstable total hip arthroplasty? Again, history and physical exam are very important. So we should, the history uh, should give us good information regarding mechanism of dislocation, any symptoms of infection. We should evaluate all the previous documentation, what was the approach used, any intra and postoperative complications. And then in the physical exam, we should look for any spine deformities, and if the hip has been reduced and if the patient comes back for a recurrent dislocation, evaluate the gait, any fixed and mobile pelvic obliquities, soft tissue contractures. We should evaluate the abductor strength, and also the distal neurological sensation should be evaluated. And it is very important to rule out infection following any hip dislocation. So we should get SED-rate and CRP, and if there is any suspicion, they should be aspirated to rule out the possibility of hip dislocation. Next step would be good quality AP and cross-table lateral views to evaluate the hip abduction, the inclination angle. It's the angle between the face of the cup and the line passing through the teardrops typically. And then the offset of the cup, which is the distance from the center of rotation to the teardrop. Offset of the stem is the distance from the center of the stem to the center of rotation, and then the height of the hip center of rotation, which can be measured from the teardrop line. And then we should look for the stem alignment and any subsidence. Anteversion of the cup can be measured with a good quality cross-table lateral view. It can give a good idea about the anteversion of the stem also. Um, just a couple X-rays showing anterior and posterior dislocation. Posterior dislocation, typically you can see the left trochanter is less prominent, and then anterior dislocation, the left trochanter is more prominent. So if if the X-rays are not satisfactory, CT scan is the next step, and it's typically considered a gold standard. So when evaluating the acetabular cup position, we should measure the anteversion of the cup with respect to the ischial tuberosities, and that can give a good evaluation. And the femoral component positioning, the anteversion is measured in relation to the distal femoral epicondyle, and this needs a proper software to measure these things. So there is people have tried to, many authors have tried to classify the dislocation, but now the classifications are commonly used. But these can be grouped as early and late instabilities, and whether they are traumatic or not, whether they are anterior or posterior, and the relationship of the components should be evaluated. Typically, those dislocations which happen within the first 6 months, they are considered early dislocations. And the common causes are infection, inadequate soft tissue tension, component malposition, and patient non-compliance also. The intermediate period would be somewhere between 6 months to 5 years. Again, component malpositioning is an important factor. Impingement and abductor mechanism dysfunction can be an important factor in this. In late dislocation, which happen like beyond 5 years, polyethylene wear is an important risk factor. And deterioration in the muscle mass and any neurological impairment of the patients are important factors to be considered in late dislocations. So this is a algorithm demonstrating, how we how we evaluate total hip dislocation. So I'll go through this chart, and then we'll talk about them in detail. The first, as I mentioned earlier, infection workup is very important in total hip. When we are dealing with hip dislocation. So in a first-time dislocator, again, history is very important, whether it is from a trauma, significant trauma, or it is something like more of a spontaneous or without a significant trauma. And X-rays should give us good information regarding any loosening, any implant failure, and malpositioning of the components. If we see any of these issues, then definitely we should consider revision surgeries because these need to be fixed. If there is no evidence of any loosening, no implant failure, component positioning looking good, in a first-time dislocation again, then we should consider the patient for a close reduction. Again, this should be done under some type of anesthesia with good muscle relaxation. And then after the hip is reduced, it should be evaluated dynamically under fluoroscopy to look for stability of the hip joint. If it is stable, then that patient is a good candidate for managing non-surgically, and they should go through occupational therapy, physical therapy, and some type of a brace should be used. If we are not sure about these on the x-rays, then definitely a CT scan is a good imaging study to further evaluate the component positioning. Again, if the implant positioning is good, no loosening, no failure of the implant, then he or she would be a good candidate for close reduction and conservative management. And if we see any of these problems, then they should be considered for revision surgery. So in recurrent dislocations, again, we should do basically the evaluation would be similar. Again, x-rays, or if necessary, CT scan. If we are happy with the implant positioning, no evidence of any implant failure and loosening, then depending on the number of dislocations, typically most surgeons consider if the patient has dislocated more than twice, something is wrong and that needs to be fixed. So revision surgery is most often considered in recurrent dislocation. If the patient compliance is a problem, then a component exchange, and possibly we should consider dual mobility cups and elevated liners. I'm sorry, if the patient is compliant, then we should go for appropriate revision of the cup. If the patient is not compliant, like in elderly patients, then they are a consideration for constrained liners. So the non-surgical treatment option, close reduction should be done under some type of anesthesia. Again, general anesthesia with good muscle relaxation is the way to go. It has a better success rate when the range of motion is stable with the hip in 90 degrees and up to almost 45 degrees of interrotation. And they should be evaluated dynamically under fluoroscopy after the hip is reduced. And post-reduction x-rays demonstrate concentric reduction, and the alignment is acceptable, and the position of the component is acceptable. In this study by Fraser and colleagues demonstrated no further dislocations in 67% of these patients. About 33% recurred, and 3 to 6% were not reducible. Again, they should be using some type of a hip spica type of brace for up to 6 weeks. This should limit flexion in posterior approach and should limit extension in patients with anterior approach. And knee immobilizer can also be used, and as you know, when they can't flex the knee, they won't be able to flex the hip joint much. The non-compliance with this could be a important problem, because patients don't want to be in a brace for 6 weeks. So the indications for surgery, typically if there are more than 2 dislocations and they have failed the conservative management, they are indicated for surgical treatment. Irreducible dislocations, definitely, and the radiological evaluation demonstrate malpositioning components, inadequate soft tissue tension, and failure to gain a concentric reduction. Usually it's because of some type of interposed soft tissue or a piece of cement or a piece of bone could be the problems. So the paramount importance is identifying the cause and all the causes of instability, and they should be addressed. All of them should be addressed when we are considering a revision operation. If they are not addressed properly, then we know many studies have shown that there is a high risk of recurrent dislocation. So these are all the surgical methods that can be done to to treat a hip dislocation. So a revision of the components if the components are malpositioned, augmenting the soft tissue tension by exchanging the modular components like the femoral head and the stable liner. And if there is impingement that needs to be addressed, larger femoral heads are an important consideration, and also dual mobility heads, and then constrained liners in appropriately indicated patients. Soft tissue reinforcement if necessary. There are some operations where if this have been reported. And then the last option is girdle stone arthroplasty. Again, component revision. When we are considering component revision, we should properly evaluate radiologically. So what's the problem, and is it the cup or is it the femur stem? So if it is the cup, we should bring it back to when we revise the cup, it should be appropriately positioned. And typically we should shoot for about 40 degrees plus or minus 10 degrees of inclination, and about 15 plus or minus 10 degrees of anteversion. Again, the cup should be placed in appropriate medial lateral position, appropriate height. If it is medialized too much, that increases the risk of bony impingement with the pelvis. And restoring the appropriate height is very important. If the hip center is raised more than 35 millimeters above the teardrop, the dislocation rate has been found to be close to 11%. So it's important to restore the height and the medial lateral position, and also the anteversion and inclination of the cup. Femoral component position alone is rarely an isolated cause of instability. If it is placed beyond 15 degrees of anteversion, there is a higher tendency towards anterior instability, and if it is retroverted, again higher tendency toward posterior instability. How do we augment the soft tissues? If the position of the component is satisfactory, then we can increase the soft tissue tension by increasing the neck length, and by increasing the offset by changing the liners. So impingement. The prominent osteophytes and cement, these can be sometimes seen on the preoperative radiographs. And if it is soft tissue, sometimes we might be able to see that intraoperatively, like a big piece of labrum which has not been removed, or capsule which is impinging between the cup and the femoral neck. This and component malposition again is a cause for impingement, which causes the impingement between the articular surfaces. And again, the position of the cup or the stem, if the proper length and offset is not restored, that is a risk factor for extra-articular impingement or the bony impingement, and these need to be addressed also. So augmented liners is one way to change to increase the stability of the hip joint. If we are happy with the position of the cup, initially we can definitely try using a posterior lip liner, which increases the posterior stability. This is a posterior lip liner as demonstrated in this picture here. This is suitable in situations where an uncemented shell is well fixed and it is still in acceptable position. But if it is not in acceptable position, just changing the liner and increasing the posterior coverage by using an elevated lip liner is not going to be helpful. These are other types of liners. These increase the offset of the hip joint. This is a lateralized liner. This will bring out the hip center rotation more laterally, thereby increasing the offset. This is a phase changing liner. This will increase the offset and also increase the posterior coverage by changing the orientation of the cup. Larger femoral heads, again, these have been extensively studied, and many authors have demonstrated that for the same neck diameter, a greater range of motion is achieved before prosthetic neck starts impinging onto the cup with a larger diameter. And now it is a standard practice to use at least 32 millimeter and maybe even 36 millimeter heads, commonly in primary hip arthroplasties. So this, by increase the femoral head, this decreases the risk of impingement, and a greater displacement is required to dislocate the larger heads before they start impinging. But many authors have also demonstrated there is a higher risk of increased wear, because the increased surface area of contact when we are using larger femoral heads. Uh, Dual mobility liners are, again, there. These have been used for many years, and with the recent generation dual mobility liners, these are an important addition to make the hip more stable. Regular size femoral head component. This is how a dual mobility liner looks like. Basically, it's a regular size femoral head in size a larger size poly liner, and this is fitted with snap fit into the poly liner, and this will then articulate into a metal liner. So this is indicated in primary arthroplasties where there is a higher risk of dislocation, like elderly patients, patient with neuromuscular conditions, any other connective tissue disorders, and when we're doing a total hip in femur neck fractures, and also in revision total hip arthroplasties, and for especially when you're doing a revision for instability and patients with abductor deficiency. This is dual mobility liners have been found to improve the stability of the hip joint by increasing the head diameter and by improving the jump distance. Um, Increased wear has been a concern with these, again, because the wear can happen between the poly liner and the metal liner. In the outer articulation, it can happen in the inner articulation. It can happen between when there is an impingement between the poly liner and the neck. But with the newer generation dual mobility liners, this has been found to be less of a concern. In this study, this was an in vitro study in a simulator, and Gordon and colleagues demonstrated that the wear performance of dual mobility bearing was comparable with standard bearing total hip, and improved polyethylene and adoption of thinner and smoother trunnions and chamfered rims and eccentric centers of insert and shell rotation have been found to reduce this wear problem, in at least in short and medium terms. So this is less of a concern now. Interprosthetic dislocation of these dual mobility liners was a concern. Again, in the first generation type of dual mobility liners, this also has been improved significantly in the newer generation of dual mobility liners. In this study by Levin, 693 dual mobility revision total hips, which were done after 2010, the intraprosthetic dislocation was just 0.2%, as compared to 2% in the earlier version of the dual mobility liners. Constrained liners can be utilized. Again, these can be indicated in patients with well-fixed components and well-positioned components, but still has instability after revision to a larger diameter, after you try to restore and increase the offset and try to increase the cup. And in patients with soft tissue deficiencies and patients who are elderly patients who are low demand, the constrained liners could be a good technique, but they should not be used indiscriminately, because these have shown that they have a higher risk of repeat dislocation up to 29%, and they can fail. The different modes of failure of these constrained liners can be loosening of the stabber component, excessive polyethylene wear, and they again can dissociate. The femoral head can dissociate from the liner, or even the breakage of the constrained liner can happen. There are some other techniques which have been defined in the literature. which can be utilized in some circumstances. Trochanteric advancement, again, this is not used commonly now because with modular components, then trochanteric osteotomy is not a common technique. This can be utilized when the components appear to be oriented satisfactorily and no other cause is apparent, and when we have to increase the abductor tension by advancing the trochanter. This can improve the stability. Again, in some late dislocations, when the underlying cause may be stretching of the soft tissues with time, and also particularly in case of monoblock femoral components. With more modular type of femoral components, we have so many different options to improve the soft tissue tension. Um, Ischiofemoral ligament reconstruction has been defined. This was a study involving only 5 patients. Basically, they used Achilles tendon to reconstruct ischiofemoral ligament. Again, this is in posterior approach, and they found no recurrent dislocations at a mean follow-up of 47 months. This is something to keep in mind. Facial latoplasty has also been defined. This study, they demonstrated, they basically what they did was when there is a deficiency of abductors, facial lata was divided about 10 centimeter proximal to the knee, and then it was a 4 centimeter wide proximally based flap was then tunneled subcutaneously, and then it was then brought underneath the vastus lateralis and then fixed to the acetabulum, um, thereby creating a sling. And they demonstrated that 16 of the 18 patients with posterior instability were then they were able to stabilize them. The last option, when everything else fails, again, in very low demand patients, this is like a salvage procedure. A girdle stone resection may be considered. So the take-home message: so the risk of dislocation can be minimized. So it's very important that a good total hip arthroplasty is done to restore the normal anatomy by proper surgical technique and proper preoperative planning. And when we are treating, initially we should consider close reduction and bracing. It is successful in most of the first-time dislocations when there is no significant problem with the component position. So when we're evaluating an unstable total hip, again, the most important thing, we should look for any implant malposition, loosening, and if we find them, definitely they need to be revised. If the implant positioning is satisfactory, then we should look for other causes. Impingement is an important factor. Then we can try to reduce this impingement by using larger heads, dual mobility heads, elevated liners, and different types of liners, which can increase the offset and change the face of the cup. If it is secondary to soft tissues due to abductor dysfunction, if it is secondary to laxity, again, increase the soft tissue tension by increase the neck length and the offset. Trochanteric advancement may be considered. If it is trochanteric non-union, again, this is a very less, a rare problem nowadays. Again, they need to be further advanced and reattached. If it is incompetent, if the abductor function is completely incompetent, then dual mobility liners and constrained liners are important techniques. And if it is secondary to polyethylene wear, then just exchanging the modular components should be able to make it stable. All right, that's it. It's a long one. Thank you. I hope addressed. I hope I covered it in detail.
Thank you, Prabhu, for yet another brilliant talk from your side, and it was very comprehensive and very clear. A couple of questions, Prabhu. There's a lot of discussion happening with the dual mobility cup. For example, in the Journal of Arthroplasty, there's a Twitter handle, and I don't know whether you have looked at this paper that's from the Australian Orthopaedic Association National Joint Registry, and they've looked at close to 100,000 hips, and they've compared dual mobility versus a large femoral head, and they've said that the revision rates for dislocation as well as loosening are comparable. So do you think there is a role for a dual mobility for a slightly younger patient, not for those with cognitive dysfunction, for arthritis, say for example, those in the 50 to 60 age group, do you think there could be a role for the dual mobility? What are the revision rates, not according to this paper, otherwise?
Yeah, definitely, that's a good question. So, dual mobility, just like any like the constrained liner. So, I don't think we should be overusing it. In there has been many questions regarding should we be using dual mobility in almost everybody. People have looked into that, but I don't think we have enough long-term data. And I'm not aware of that that paper, but it does look like once during the last 2 decades since you've been using these larger femoral head 32 and maybe even 36, the risk of dislocation and instability has been significantly reduced. So I don't think we should be considering dual mobility for a primary hip in an otherwise even in young patient and otherwise regular hip arthritis. But if it is something, if there is anything, any complicated, if there is any issues with the soft tissues, previous, previous hip surgeries, then maybe it's a consideration. Yes.
Thank you, Prabhu, for that. And the other question is those patients who have a coexisting spinal deformity. How do you go
Hmm.
ahead? Do you risk, I mean, advise them to undergo a spine surgery prior, or do you do the hip, or what is that which decides on how do you approach it?
So depends on the spine problem they're having. Many patients when we see with significant hip arthritis, it's not uncommon for them to complain about back issues. A lot of elderly patients will have degenerative spine disease with reduced mobility. So unless it is something serious, many patients have back pain, but without any neurological symptoms. If they have significant neurological symptoms, yes, they need to be evaluated by spine surgeons to see if there is any indication for spine surgery first before we proceed with hip replacement. But those who just with back pain issues, I will evaluate them clinically to see to look for the amount of deformity they have in the spine, and obviously we should do the proper X-rays and look for how much stiffness they have. Um, and if it is severe stiffness, then if that is not their main problem, I don't think spine surgery needs to be considered. So we should plan an appropriate. We should plan to position the components appropriately to decrease the risk of a dislocation. So again, probably anterior approaches, lateral approaches may be a consideration in those patients to decrease the risk of posterior dislocation, because we know the problem is when the spine, when the pelvis is not moving appropriately, that increase the risk of a posterior dislocation.
Thank you, Prabhu, for that. And also there is some interest in the EO software, right? A lot of centers have taken up the EO software and they look at, especially those with coexisting spine deformity, and helps measure the pelvic inclination, the anteversion,
Mhm.
sacral scope. What has been your experience? Does your center have any of the EO software, or is it available in that part of the world?
It's so I don't have we don't have that in our center, but I think robotics, as as far as I know, robotics has been um, people are adapting robotic technology more and more, and many robotic technology have included this software, so where you can assess the pelvic tilt and the pelvic mobility, and you can actually get a good idea about where the impingement is happening, depending on the various positioning of the cup. It is definitely a very good addition that will improve the positioning of the component, thereby decrease the risk.
Thank you, Prabhu. For just one last question before we wind up the session.
Mm-hmm.
What is the complication rate when you do a total hip for a femoral neck fracture? For example, if 10 years back, if you told, I mean, there was some concern about a higher risk of dislocation for a total hip replacement in the setting of a femoral neck fracture. What is the current consensus for that?
It is still, it is still it's a higher risk compared to when you do a total hip for an arthritis patient. But we know it is a higher risk. So certain things we can do to decrease the risk are again, maybe consider either a lateral approach or maybe an anterior approach for hip replacement, and larger femoral heads for sure. Maybe dual mobility liners are they need to be considered when you're doing a fracture neck femur, total hip arthroplasty and fracture neck femur. And many times, as you know, these are more often elderly patients, low demand, and we often tend to do hemi-arthroplasties, which are obviously larger heads. So that also decreases the risk of dislocations.
Thank you, Prabhu. I think that's all the questions that we have for this session. Fantastic lecture as usual. And I'm sure this lecture is going to benefit a lot of people all over the world. Thank you so much for joining in, Prabhu.
Thank you, Vitesh. My pleasure. So, yeah, I hope it's going to help.
Bye-bye.